Good afternoon, everyone. Welcome to today's webinar hosted by Patagonia Health. Today's webinar topic is on assessing and treating suicidal thoughts and behaviors. If you're not familiar with the Zoom webinar platform, take a look at the control panel at the bottom of your screen. Here, you can configure your audio settings, send chat messages, and ask questions. Dr. Ross did say that she would be open to questions at the end of the webinar. And just so you know, this is recorded and a copy of this recording will be sent to your email after the webinar. As a quick background to our speaker, Dr. Jacqueline Ross is a clinical psychologist who specializes in mood, anxiety, and trauma disorders, as well as PMDD and borderline personality disorder. Dr. Ross has expertise in assessing and treating suicidal thoughts and behaviors. She received her PhD from UCLA and completed her clinical internship at Northwestern University. She is the founder of a Chicago-based private practice specializing in evidence-based treatments for mood, anxiety, and trauma disorders, as well as premenstrual disorders. Without further ado, I'm going to pass it over to you, Dr. Ross.
All right. Once again, thank you so much for that introduction, and thank you for having me. As was already said, I'm Jackie Ross, and I'm really looking forward to speaking to you all today about assessing and treating suicidal thoughts and behaviors. So I have several goals in today's presentation. First, I plan to present current data on suicide prevalence and common challenges to suicide prediction and prevention. Second, I hope to highlight new directions in suicide risk assessment and intervention. Next, I'm going to present evidence-based assessment of suicidal thoughts and behaviors. And finally, I'm going to introduce dialectical behavioral therapy, or DBT, as an effective behavioral treatment to address suicidality. And then finally, at the very end, I'm going to provide some practical guidance for integrating high-quality, evidence-based suicide risk assessment and management within therapeutic sessions. So first, a little bit on suicide prevalence and significance. So according to the latest CDC data, 49,000 people died by suicide in the United States in 2023. That is one death every 11 minutes. And suicide rates have increased by 37% between 2000 and 2018. 12.8 million adults seriously thought about suicide. 3.7 million adults made a suicide plan. And 1.5 million adults attempted suicide. So these numbers are quite alarmingly high. So to take a closer look demographically at what's driving some of this. So first, when we're looking at racial and ethnic differences, as of CDC data from 2022, we see that suicide rates are highest among American Indian and Alaska Native populations, followed by white people. As far as age goes, we know that suicide rates are highest among older adults. And as of 2022, the next highest group is adults ages 25 to 34. And then finally, we do see pretty profound sex differences in suicide death rates. Specifically, we see that rates of suicide death are much higher among males, with about 22.8 versus 5.7 for females. And although these suicide death rates are much higher among men, we think that this is likely due to social factors like increased access to lethal means such as guns. And it's worth noting that women make far more attempts than men, even though the death rates are higher among men. To speak a little about methods of suicide-related deaths, we see that 24.38% of suicide-related deaths as of 2023 were related to suffocation. 12.1% were related to poisoning. Then there's the small other category. But what is striking is that over half, 55.3% of suicide-related deaths were completed via firearm. And this startling graph shows that our trend in suicide rates over time is not looking so good. So we're seeing current suicide rates in the United States are at a 30-year high, with over 40,000 annual suicides and 117 daily. In the 1970s, by comparison, the risk of being killed by someone else or in a car accident exceeded the risk of suicide. But today, suicide is more prevalent. And what's really challenging is that, in combination with the fact that we're seeing these alarming trends in increased suicidality nationwide, we also in research do not historically have a great track record of predicting suicide. Like I mentioned, current US suicide rates in the United States are at a 30-year high. And traditional factors like depression and substance abuse and stress and history of suicide attempt, our research is showing that these are all actually pretty poor suicide predictors. None of these predictors was better than chance when put into a statistical model. And a meta-analysis of 365 suicide studies by Franklin and colleagues revealed flaws in past research methods, leading to inaccurate research factors. And what I mean by that is that this past research has been flawed because it typically focused on a single trait-level risk factor, such as depression. And by that, a diagnosis of major depressive disorder or low serotonin in the brain. And then it followed these patients who were deemed to have this trait level unchanging risk factor. It would follow these patients over a decade. And that type of long-term approach produced this incomplete understanding of risk factors that did not accurately identify who actually needed mental health assistance. And the problem there is that we were focusing too much on these stable trait level factors and not enough on time varying factors. So new approaches are leveraging AI and machine learning to identify more accurate risk factors. More of that work is being proposed and tested in its early stages. And what we really need is more emphasis on these state-like, time-varying factors in addition to more trait-like stable factors, right? State-like time-varying factors might be loss of employment or a particular emotional symptom on a given day, certain biological factors that change over time. We need these kind of more state-like, more time-varying factors to better understand who is at risk and when they're at risk. So there are some challenges in working with suicidal patients, and these are some of the challenges that may lead some providers to hesitate when working with suicidal patients. First, there's the risk and liability concern. So legal and ethical concerns may arise. Providers worry about potential liability if a patient harms themselves despite treatment. It can also take an emotional toll, right? There's an emotional burden of caring for suicidal patients that can become overwhelming, and providers may experience burnout. We also know that there's limited resources in certain settings, such as overcrowded emergency rooms or understaffed psychiatric units. Resource constraints can actually hinder effective crisis intervention. We also know that complexity of care can present challenges. So suicidal patients often have really complex needs, including comorbid mental health disorders or co-occurring substance use issues. And treating them often requires a comprehensive and multidisciplinary approach, and not all mental health treatment settings are set up to provide that. And finally, lack of training. Some mental health professionals may not receive adequate training in suicide risk assessment and intervention in their education, which can lead to discomfort and just lack of knowledge when working with suicidal individuals. So addressing these challenges is really crucial for improving suicide prevention efforts and ensuring that providers have the support and the training necessary to treat suicidal patients effectively. So let's talk about the new things that we are learning that can increase our confidence in suicide prediction and prevention. So first, there's this shift in focus from stable trait-like suicide risk factors to time-varying predictors of suicide risk. So new work is establishing the following symptoms and experiences as time-varying correlates of suicidal ideation and behavior. First, at the daily level, sometimes even at the momentary level, depending on the study, we know that certain emotional experiences like depression, stress, feelings of worthlessness, feelings of overwhelm, feelings of anger, anxiety, and perceived rejection can all increase suicidal ideation. And this isn't just, I have these experiences in general and therefore I'm more suicidal. It's on the day when I have this experience, I also experience suicidal ideation that day. That's getting at this time varying piece. We also know that job loss and severe interpersonal conflict are associated with suicide attempts. So in a relative amount of time, when I've experienced a job loss or a severe interpersonal conflict, around that same time, I'm more likely to make a suicide attempt. And then just to highlight one maybe the only recurrent predictable biological factor that we've learned is a known correlate of suicide risk is the perimenstrual phase of the menstrual cycle, which means those days around menses, which is significant given that although more men die by suicide, more women make attempts. And we know that perimenstrual phase of the menstrual cycle is associated with increased suicidal ideation, increased suicidal planning, and increased likelihood of suicide attempt. So this is some research. This is a figure pulled from some research that I published along with my team in 2024 in the American Journal of Psychiatry. And this really highlights the importance of individual differences. So what this graph is showing is how all of these different emotional symptoms are basically correlated with suicidal ideation at the daily level. So on a given day, when you experience agitation or anger or anxiety or depression or hopelessness or conflict or loss of interest or overwhelm or perceived burdensomeness or rejection sensitivity or worthlessness, on a given day when you experience any of these given symptoms, how is that associated with the degree of your suicidal ideation on that given day? And there's two things that I want to draw your attention to from this graph. First, nearly all of those symptoms that I listed out are correlated with suicidal ideation at the daily level, with the exception of anxiety and loss of interest. So those two doesn't seem like they're so strongly correlated with suicidality, but all those others are to varying degrees. So in general, we've got all of these factors that we can say, yes, if you experience this feeling on a given day, you're more likely to think about suicide that day. But I also want to draw your attention to the huge individual variability in how strong these correlations are. And that's when you see these kind of big bumps in the middle, and then we got these thin lines at the end, that's really capturing where most people are falling, where there's more thickness in the graph, and then it's fewer people falling at these more thin lines at the tops and bottoms. And what we're seeing is that for some people, you might have a really strong association between one of these symptoms and suicidality, but it's not like that's true for everyone for all of these symptoms. For example, for agitation, we're seeing, wow, a lot of people who experience agitation on a given day also experience more suicidal ideation on that day. But then we see these other people where it's not correlated at all. Right? So this just highlights the need to build models that can take a tailored individual approach, right? Because for one person, rejection sensitivity, or for one person, perceived burdensomeness might be the thing that drives their suicidal ideation. But for someone else, it might not be that at all. It might completely be feeling worthless, right? So we really need to look at this at the individual tailored level. And this is where some new ideas and technology are coming into play, specifically these just-in-time adaptive interventions for suicide prevention. So these adaptive interventions that provide support based on individual needs and contexts to address time-varying suicide risk. So here are the important components of these models. First, there's decision points. These are the times at which interventions are delivered, aligning with moments of highest need. Then there's a suite of intervention options. This is the set of treatments that can be provided at a given decision point, and it's tailored to the individual's current context, such as sending activity suggestions when weather permits, right? Oh, we see that you're experiencing more depression and hopelessness today. We're also seeing that the weather is sunny. Can you go for a walk? Also, tailoring variables. So this is contextual information used for decision making, gathered passively or actively. I gave the example of the weather data a moment ago, or the self-reported mood. And then finally, decision rules. These are the formal rules that govern when and which intervention option to offer based on risk level. For example, for someone who is more high risk in a given moment, right? They're starting to report suicidal ideation on whatever smartphone app we're theoretically using for this model, and then they are automatically sent an offer to meet with a clinician. Right. So these are the kinds of technological advances that we're hoping to make. If these could be digital interventions that people have access to, the thought is that this could really move our efforts towards suicide prediction and prevention forward. However, there are challenges in suicide prevention with these just-in-time adaptive interventions. First, the measurement of real-time suicide risk. Implementing these types of interventions requires real-time assessment of suicidal thoughts. So there is a need for better reliability and validity of self-report measures of suicidality in the moment. Next, there's this issue of balancing risk and receptivity. So we need to find the right times to intervene. That's crucial. These just-in-time adaptive interventions, they need to consider both an individual's vulnerability to risk in a given moment, but also their level of receptivity to an intervention in a given moment. Because as suicidal thoughts increase, in severity, we can also assume that individuals may become less receptive to interventions. So these models need to figure out how to account for that. There's also ethical considerations when it comes to real-time digital interventions like this. So conducting real-time monitoring of high-risk individuals raises ethical questions about informed consent and privacy and confidentiality and when and how to intervene. And we need to strike a balance between participant safety and effective intervention, right? Because we want people to be honest. And if they know that that a certain answer is going to result in immediate hospitalization, one's going to be honest. So we have to figure out, how do we balance keeping people safe, but also not scaring them into being dishonest? So there are some future directions that could be useful for suicide prevention with these just-in-time adaptive interventions. First, identifying states of risk and receptivity. Research needs to focus on how to identify those states. We need to have more work on matching mechanisms and outcomes and interventions, really understanding how do we develop a comprehensive suite of predictors for suicide risk, along with corresponding intervention components that can help reduce suicide risk. For example, if someone is really behaviorally inactive, they're deep in the throes of depression, and they're just lying in bed all day, then probably the matching intervention from that is going to be encouraging them to start taking some baby steps towards more behavior activation, right? Getting out, calling a friend, taking a walk, those kinds of things. Whereas if it's really anger and agitation that's driving suicide risk for someone else, we would want this digital intervention to know about the anger and be able to coach them on skills for managing that to reduce suicide risk via different emotion regulation skills and assertiveness skills to communicate effectively rather than with kind of reactivity. And then finally, we need to figure out how to integrate these kinds of digital interventions into clinical care. I think that these could be really compatible with ongoing psychotherapy provided by a person, not a smartphone. So exploring how these models can complement traditional clinical care models is essential. It might be that we use something like this when someone is on the wait list for therapy, but I think it also could be used as tools to promote skills use between therapy sessions or during transitions between inpatient and outpatient care, or for people who do not have access to traditional therapy. Maybe this is the alternative for those people who can't get connected with a therapist either right now or whatever. So that's some background on where we're headed, especially on the research front, in terms of continuing to refine our ability to predict and prevent suicide. But I want to speak more about assessment because the most critical step in building confidence and competence in managing suicidality is to develop strong assessment skills. So the Columbia Suicide Severity Rating Scale, the CSSRS, this is the gold standard for suicide risk assessment. So first, this creates a common language for assessing and conceptualizing suicidal thoughts and behaviors. It increases our ability to predict risk and provide information for better assessment of suicidal intent. That's how seriously you're actually considering acting on a suicidal urge and plan. It reflects change over time. It doesn't have to just be a one-time measure. We can actually give this repeatedly to people and see how their answers are shifting. It can be administered inpatient or outpatient, and there's a full version and a screening version. And I am including a link here for anyone who's interested in looking at this more. And I will share the slides at the end so that you can get any links you need. Okay, so the key components that are assessed with that CSSRS. First, we're always going to get at suicidal ideation, which is thoughts of wanting to die or thoughts of killing self. It will also assess the intensity of that ideation, and it will also assess suicidal behavior, and that is actual attempt. Have you actually made a suicide attempt? And if so, understand the lethality, right? Did you take a few extra of your prescribed Prozac, or did you try to hang yourself? Those are associated with very different degrees of lethality, and that'll help us understand how at risk is this person moving forward. It will also assess for interrupted attempts. So that is, you were going to attempt or mid-attempt and something or someone stopped you, versus aborted attempt, which is you were in the middle of an attempt and you decided to stop. And it will also assess for preparatory behavior. Have you done things like write a will, write a goodbye letter, made any preparations for kind of your belongings after you go? Have you kind of arranged your methods and means, all of those kinds of things, which would once again make us pretty concerned about risk. In assessing suicidal ideation, there are all of it's concerning, but to varying degrees, right? There's the wish of wanting to die. Then there's non-specific, but more active suicidal thoughts about actually wanting to kill yourself. But then it's really when we're getting into this active suicidal ideation that we get more concerned, and especially when we get over to these last two. So first, for active suicidal ideation with any methods, so without a plan and without intent to act. So that's this one here. To assess this, we ask, have you thought about how you would kill yourself? What did you think about? If someone is saying yes to this, I have thought about killing myself, but I haven't really come up with a specific plan, and I don't have any intention to act on any specific plan at this point. This is already concerning, but it's the point where we would just be considering safety precautions. You would be safety planning with this person to help them figure out, okay, what would you do if this got worse? Who could you call? What are coping strategies that have worked for you in the past? Do you know the suicide hotline and what it means to take yourself to the hospital under these circumstances? Is there anything we can do to reduce stress or to make your environment safer now? For example, if you've always considered driving your car into a tree, can we maybe plan ahead of time that on days when you're noticing you feel more emotionally raw, you don't drive your car, you take the bus or you take an Uber on those days, just to remove any of that consideration. That's the kind of just considering of safety precautions that we would do if there's that active suicidal thought, but without a specific plan. Versus once we're getting into active suicidal ideation with some intent, but without a very specific plan. First, we assess this with a question like, when you thought about killing yourself, did you think that this was something you might actually do, as opposed to having thoughts but knowing you wouldn't do anything about it? If someone is saying yes to this, more safety monitoring is needed. They're probably going to need more regular contact with a clinician. We're going to want to make sure that we're really keeping a close eye on this person. We're still doing all of that safety planning that I mentioned before, but we're also probably going to need, in an outpatient setting, I would want to be communicating with this person probably outside of our weekly session. And I would also want to, during our weekly session, be getting commitments to safety each week. How are we going to keep you safe through to the next week? Finally, we have active suicidal ideation with specific plan and intent. We assess this by asking, have you decided how or when you would kill yourself? Have you planned how you would do it? What is your plan? When you made this plan, was any part of you thinking about actually doing this? If someone is saying, yes, I have a specific plan and I have some considerable degree of intent to act on it, this is when really urgent action is needed. This is when we're considering breaking confidentiality. This is when we're noticing the limits of confidentiality and considering breaking confidentiality to get a loved one involved. This is when we might be talking about hospitalization, depending on how long the person is able to commit to safety. But this is when we're saying, I don't want you to leave my office, when you're endorsing this level of suicidal ideation. And then finally, suicidal behavior is the stuff I mentioned before. Have you done anything to start preparing? How long ago did you do this? And all of this, once again, is just helping us understand how serious is this? Do we know a timeline so we can make some informed decisions with that information? So that's the bulk of it when it comes to good suicide risk assessment. Now I want to talk about good suicide risk treatment. And this is where I introduce dialectical behavioral therapy, which is an evidence-based treatment for suicidality. So DBT, what is it? So first, DBT was designed for the severe and chronic multi-diagnostic and difficult to treat patient. It was originally proposed in research contexts for people with borderline personality disorder and suicidality. Borderline was chosen in those early research trials, mostly just because it was a population where there is a high degree of suicidality. And DBT it's behavioral. It's very focused on building behavioral skills for emotion regulation and distress tolerance and interpersonal effectiveness. It's cognitive. It has an emphasis on changing your thoughts and noticing your thoughts. It is skills oriented. It's all about building skills. If any of you have had any exposure to DBT, you might know that it's just a million snappy acronyms for different skills and names to help people feel more equipped to regulate their emotions. It's supportive and collaborative, right? We are a team in helping you build the life that you want to live. And it balances acceptance and change. And this is where I think it moves a little beyond traditional CBT, because rather than just focusing on changing thoughts and behaviors, it also really emphasizes accepting what cannot be changed and acknowledging the limits to your own power and control. So in order to be considered a fully adherent or full model DBT program, you need to have 4 components. And for individuals who are at elevated risk of suicide or self-harm, I really believe that they should be in a comprehensive DBT program. Just having an individual therapy session that is informed by DBT is likely insufficient for a client who has marked suicidality or self-harm. So for those patients who are higher risk, to do a full DBT program, first, they need individual therapy. Those individual therapy sessions involve functional chain analysis of behavior, which we'll talk more about in a moment, and they deliver interventions to address target behaviors. It includes a skills group, which is really structured a little bit more like a class with a dash of support group mixed in, but it's really didactics on skills that move systematically through modules. There's phone coaching, which involves crisis intervention. So for moments where there really is elevated risk of suicide or self-harm, phone coaching is appropriately used in those moments to intervene in a crisis. But it's also just used for skills generalization. Rather than us just talking about skills during session, in the moment, I want you to call me and say, hey, I think I need to use a skill right now, but I don't know which one. Help me figure it out. And then the fourth component is consultation team, which is where a group of clinicians meet to discuss challenging cases and help each other kind of treatment plan effectively, select interventions, and make sure that they are managing life-interfering behavior, suicide risk appropriately. And it's also a space for reducing therapist burnout, both because it helps therapists who are working with these high-risk patients feel less alone in the risk management, but also because it's a place to get some validation and just camaraderie among clinicians. Like I mentioned before, a key component of individual therapy in DBT is functional chain analysis. So if a patient comes in and says on their diary card, which is the weekly form that they complete each week to tell us about the emotions and behaviors that they experienced on each day of the week since our last appointment. If I see that they have had any suicidal ideation or self-harm or suicidal planning in the past week, we're going to talk about it and we're going to do a functional chain analysis to understand what caused it. We're going to identify the vulnerability factors that were at play. Those can be just the things that set the stage for it to not be such a good day, the things that just made you more vulnerable going in. We'll identify the prompting event, which I often think of as the tipping point. What was the thing that tipped you into this mode of starting to think about suicidality? We'll talk about the different links in the chains. That's the emotions, the behaviors, the back and forths that got you to your problem behavior. And then we'll talk about the consequences, right? Let's say you did engage in self-harm, or let's say you did Google how to kill yourself. We'll talk about what were the short-term consequences of that and what were the long-term consequences of that. So to illustrate, I'm going to give an example. Let's call a patient Hannah. Imagine that Hannah is a 25-year-old who has BPD and PMDD, so borderline personality disorder and premenstrual dysphoric disorder, who has made several suicide attempts over the past 10 years, 3 suicide attempts over the past 10 years. So what we know is that vulnerability factors for Hannah tend to be the premenstrual time of her cycle. We know that's a time of elevated suicide risk in general. We also know that when she's not eating meals regularly throughout the day or doesn't take her prescribed psychiatric medication on a given day, all of those can serve as vulnerability factors just to have a rougher go of it that day, just to set the stage that she is just more likely on average to experience suicidality on a day like that. Then we might identify her prompting event as criticism from her dad. Right? Her dad says something really critical and degrading to Hannah. And then that might lead to shame. There's the first link. And that might lead to this thought for Hannah of, I can't handle feeling this way. And that might lead to this urge to just escape the way she's feeling and escape this given situation. And then that might lead to suicidal thinking of, I just want to die. I'm going to start making a plan for how to die. And then we're going to talk about, okay, in the short term, what did thinking about that suicidal plan do for you? In the short term, it was a relief, right? I felt relieved. I want to escape. That gives me a way to escape. It makes perfect sense that there's relief that comes with originally entertaining that thought. But then we think about long-term consequences. It interferes with other problem solving. If the solution is that I'm going to die, then the solution is not, I'm going to figure out how to have an assertive conversation with my dad so that he stops interacting with me in this hostile way. or I'm going to do some problem solving to clean up my side of the street for whatever I got criticized for, etc. The idea being that jumping to suicidal planning is interfering with figuring out other ways to deal with the prompting event that started all of this. Another big idea in DBT is that we're treating suicidality by building a life worth living. So for many suicidal patients, life does not currently feel worth living. And we have to validate that, and we have to be willing to kind of show up for that truth, because trying to cheerlead someone and convince them why their life is great when they don't feel that way just doesn't work and ends up feeling pretty dismissive and invalidating. So we have to start with the understanding that your life as it is right now does not feel worth living. And in DBT, building a life worth living serves as the guiding principle for suicide prevention. So in my first or second appointment with someone with suicidality, we're going to work on identifying life worth living goals. And I would ask questions like, describe for me in your deepest heart of hearts, what life do you long for? What would it look like? When would you have it? What would your relationships look like? What would your career look like? Where would you live? All of these kinds of things. Can we figure out how we get you the life that you actually would want to stay alive for? And then the goal of treatment is to target the specific behaviors that interfere with meeting their life worth living goals. Right? So if we find that someone really wants to have a stable romantic relationship, but they also really struggle with these rage outbursts, I want to help them figure out how to build skills to no longer have rage outbursts, because I know that rage outbursts are directly interfering with them having a stable romantic relationship long term. That's just one example. So here are the DBT modules. First, there's mindfulness. Mindfulness enhances awareness of the present moment without judgment. Mindfulness also helps individuals recognize and manage suicidal thoughts and urges as they arise, to be able to really notice things in the moment rather than the whole day goes by, things are brewing, and you don't notice until you're at that 10 out of 10. There's also distress tolerance. This teaches crisis survival strategies for handling distressing situations. So this really equips individuals with immediate coping tools to prevent self-harm or suicide during crises. So this is, what are some fast-acting strategies we can try to keep you safe in the moment? There's emotion regulation. This focuses on understanding and managing emotions effectively. So this involves equipping individuals with skills to navigate emotional distress without resorting to self-destructive behaviors. Next, there's interpersonal effectiveness. This teaches effective communication and interpersonal skills so we can improve relationship problems, which are often the thing that precipitates suicidal thoughts and behaviors. And then finally, there's walking the middle path. This encourages the balance between acceptance and change strategies. It promotes a non-judgmental approach to thoughts and emotions while actively working towards reducing suicidality. So it's this balancing act, acceptance and change. And really, I mentioned mindfulness at the start. Mindfulness is the through line for all of this. So many of the patients I work with, yes, there are specific skills. For example, if anyone's heard of the tip skill, which we'll talk about in a second, like there are certain skills that people love because they just are really effective and very quickly. But what I find tends to lead to the most meaningful change for people is this increase in mindfulness, this increased awareness of their thoughts and their emotions and their behaviors, and feeling like they're being more slow and wise as they navigate stressors and are making decisions intentionally rather than automatically and reactively. That's the thing that seems to make the biggest difference for people. So I want to talk about suicidal behavior strategies in DBT, how we tend to manage suicidal behavior. So first, we've got some key therapeutic tasks. First, to respond actively enough to prevent the patient from actually killing or harming themselves, and to respond in a fashion that reduces the probability of subsequent suicidal behavior. So we've got this balancing act here, because on the one hand, we want to make sure that we are responding in a way that keeps the person safe. We want to take it really seriously, respond really actively to keep them safe. On the other hand, we also don't want to create a harmful dynamic where we are so warm and so communicative and talking to them constantly when they express suicidality, because then we might be accidentally reinforcing some of that. So even if it's unconsciously, they're not intentionally being manipulative. They're just learning at this subconscious level that when I'm suicidal, I get more care, more contact, more communication. So we want to make sure we're giving them the level of care they need to keep them safe, but also not being overly reinforcing of communicating suicidal thoughts. There are 3 rules for managing suicidal behavior in DBT. First, suicidal behaviors are always discussed in depth. They are never ignored, and they're always the first thing we talk about. Second, the 24-hour rule. No contact with the therapist for 24 hours after you have engaged in a suicidal behavior. So if someone calls me for phone coaching and says, I just cut my wrist, I will make sure that we figure out how to get them safe if they require medical attention. But after that, no phone coaching for 24 hours, because they've already made their decision. They've already done the thing, they've already done the behavior and not opted for skills. Phone coaching is for when we are helping them use skills to not do those things. This is once again in line with this piece of we don't want to reinforce behaviors accidentally. And I know this can sound mean and punishing. You can still be an incredibly warm and collaborative therapist while holding some of these lines. It's a hard line to walk, but you can do both. And finally, potentially lethal patients are not given lethal drugs. For example, if a patient previously attempted suicide with a prescribed benzodiazepine like Xanax, they should not be prescribed medication, benzodiazepines anymore. It's those kinds of considerations. We want to make sure that for psychiatrists, they're being really mindful of which medications they're prescribing to suicidal patients. And at a minimum, if there's medication that must be taken, like an SSRI, like Prozac, for example, we want to figure out if the person does have a history of overdosing on that kind of medication, how do we limit the quantity they have, et cetera, if that seems necessary given the level of risk here. For example, keeping like a small baggie and having the rest locked away somewhere. Okay. More on addressing suicidal behaviors in DBT. First, assessment. So we always want to be assessing the frequency, intensity, and severity of the suicidal behavior. And we want to understand the exact nature of the behavior to tailor interventions effectively. Next, we always want to do a chain analysis. We want to examine the sequence of events in excruciating moment-to-moment detail so we really understand what happened. We always start by identifying the moment of the first thought or urge to engage in suicidal behavior. We always want to highlight the negative long-term consequences of engaging in suicidal behavior, and we always want to assess alternative solutions to suicidal behavior. So often for people, suicidal behavior feels like a solution to a problem. Something has happened, or I'm having some internal experience, and I feel like there's no solution, and like my only option is to escape by suicide. So a lot of times it's helping people figure out, you don't need to die. You need to solve this problem. Let's figure out another way to solve this problem. We want to be really reinforcing of non-suicidal responses, which means we want to highlight and praise and reward non-suicidal coping strategies and responses. We want to create a crisis safety plan. So we want to collaboratively work with a patient to develop a concrete plan for coping skills to replace suicidal responses. We want to be really validating of patients' pain. We want to show empathy and validation for the emotional pain and distress that has gotten them to this point. And we want to make sure that we're bringing warmth to this. And finally, we want to relate suicidality back to patterns. We want to help patients relate their current suicidal behavior to overall patterns and triggers. Oh, it seems like this thing is always what triggers this response in you. Why do we think that is? And then over time, how do we start to target some of those triggers so that this pattern stops unfolding? So here is a DBT crisis plan. This also functions as a safety plan. And for any suicidal patient, this can be a wonderful resource. So the key components, first, observing warning signs. We want people to be aware of what are the signs that a crisis may be developing. What body sensations, like a pit in your stomach or your heart racing or feeling flushed? What specific emotions? For you, is it more sadness? Is it more shame? Is it more anger? And what situations? Maybe it's invalidation by a romantic partner or whatever some of the common triggers are. What should you look out for to know, ooh, this is where I usually run into trouble with suicidality and self-harm? Next, we want them to have that reminder of what their life worth living goals are. We should have already established those in treatment. This is just where they list out what are my short and long-term goals that I can remember to help me get through this crisis effectively. Then we've got all of these just little cheat sheet of some of their go-to skills. So at the bottom, we have this distress tolerance skill, the TIP skill from DBT, which involves first temperature, cold water. It usually means like dunking your face into ice water and holding your breath for 15 or 20 seconds, stopping and repeating as much as you need to. Intense exercise. So doing jumping jacks or sprints or squats and really just doing it until you can't do it anymore, which is usually just a few minutes, just to wear yourself out, to expend some of that energy. And then paced breathing. We love our breathing. It's just breathing into your belly and doing a slow in for 5, out for 7 count for a few minutes until you notice your body start to calm down. And then we also help people brainstorm what are their go-to distractions in a bunch of different domains. What are their favorite ways to self-soothe? And by that, we have it for each of the senses. How do you soothe your hearing? Maybe it's a certain song. How do you soothe your smell? Maybe it's a certain candle, etc. We also remind them of pros and cons. Just list out for yourself the pros and cons of acting on this suicidal urge right now. And improving the moment is another DBT skill. Then we also include on here ways to reduce risk in the environment. So that might include things like I mentioned before of avoiding your car if you're having suicidal thoughts related to the car, if you have access to guns, making sure that you no longer have that access to guns. I've worked with some people, particularly when the thought is of taking a lethal overdose of prescribed medication, that they have a little baggie that contains the medication they need on a daily basis, but the larger amounts are in a lockbox that they do not have access to. We have them write down people they can contact for distraction or for help, some suicide prevention resources that they can call, and then this nice little YouTube playlist if they want some skills reminders. I also want to quickly touch on how we deal with threats of imminent suicidal behaviors. So if a patient during a therapy appointment or during phone coaching says, I have intent to kill myself. I have a specific plan and I'm intending to kill myself. First, we want to assess the risk, what's going on short-term and long-term that would help us understand the degree of risk. We want to reference that crisis plan that we just looked at. We want to make sure that planning sheet is easily available to both the clinician and the patient so that we can look at it at any given moment. We want to make sure we're restricting means. We want to take immediate action to remove access to lethal means. The therapist should instruct the patient to do so and communicate that I'm sure you can do it. I'm confident that you can do this. That might mean like, I want you to flush all your pills down the toilet, be on FaceTime with me while you do it or whatever, so that we know it actually happened. Empathetically instruct the patient not to kill themselves. emphasize that suicide is not a viable solution, and help them to generate hope. Like I mentioned earlier, take the problem-solving approach, encourage the patient to identify what is the underlying problem here. Let's understand that suicide's not the only solution. Can we shift the focus to problem solving rather than self-injury or suicide? Maintain contact. When risk is imminent and high, maintain regular contact with the patient. We want to make sure that we are either keeping them on the line or talking every few hours, depending on how high the risk is. Confidentiality and involving others. We want to limit confidentiality when it's necessary for the patient's safety. So if the patient is not able to collaboratively safety plan with you, and it's really seeming like they're not going to be able to do this on their own, then we do need to inform a relevant party when required to ensure the patient's well-being. And for any clinicians here, certainly encourage you to have an emergency contact form that you get from people upon intake, where they already have even signed a release to say you can contact this person in case of an emergency. And finally, involuntary intervention, the absolute last resort. If the patient endorses suicidal planning and intent and is not able to commit to safety, and their support system, like someone else in their environment, also doesn't have the capacity to keep them safe, right? If we can't make a good safety plan at home, then we do need to consider the need for involuntary intervention to protect the patient's safety. To this point, we want to really avoid the hospital at all costs because it can be really traumatizing for patients to be involuntarily hospitalized. If we really have to go the route of hospitalization because risk just cannot be managed at home, then we really should aim for collaborative hospitalization, which involves a joint effort between the therapist and the patient to seek emergency care, rather than the therapist calling 911 to involuntarily hospitalize the patient. In this scenario, the therapist works closely with the patient to assess their current state and collaboratively decide on the need for hospitalization, which can really establish trust and empowers the patient in the decision-making process. If I have good rapport with someone, I can say, the way you're talking, it's really seeming like it's time to go to the hospital. What do you think? What are the pros and cons of going? And try to get them on board so that they make that decision themselves. This can also help with reduced stigma and reduced potential for a traumatic hospitalization experience, like I mentioned. Collaborative hospitalization kind of can reduce the stigma of I was thrown into the hospital, and it can help people feel more in control. Like they made this decision, they made it so that they could keep themselves safe. Okay. That's all I have for you. I do want to post here some resources. So first, these are all local to Chicago, but I do have some resources for DBT, for suicidality, at least here in Chicago. Here's a link to the CSSRS that I mentioned before. And here is the list of DBT online resources for anyone interested in learning more. Thank you so much, and I'm happy to take any questions we have in these last few minutes.
Thank you so much, Dr. Ross. That was
Yes,
very informative. We do have some questions. If you have a question, please enter it into the Q&A or the chat so I could read it out loud. The first question that we have is Angela. She says, when speaking about there was a chart in the very beginning of the presentation, and she was looking at, there was a dip in 2019 and 2020, and she was wondering what you attribute the dip to be for.
I have no idea. I really don't. I don't know. I don't think there's a good speculation either. I wouldn't make too much of it, given that it was just 1 year and then the numbers kind of rose right back up to where they were before. Yeah, I don't know.
Someone just asked, will the webinar be archived to view at a later time? Yes, it will be living on the Patagonia Health website, and we will also email it to you tomorrow. Someone just asked, when someone keeps speaking about suicide, can you share an example of how to speak to that? Becky, if you have any additional insights, feel free to message.
Yeah, give us some extra context.
So I have somebody that keeps speaking to suicide, and I'm suicidal, and the behavior made an attempt, but I want to share a long-term consequence to if you keep continuing to speak this way. What's an example of a good thing that you can share with them that this is a long-term consequence of you continuing to speak this way that maybe could direct them back in it? Oh, I guess I never thought of it that way.
I think
If that makes sense.
that does make sense. And a few possibilities. One, I think highlighting for people that if you keep speaking about suicide to your loved ones, outside of the context of really needing to help have your support system keep you actively safe in the moment, but if you're just saying often to people, like, I want to die, I want to kill myself, it can really burn out relationships because people are so worried about you and they feel so helpless. They don't know how to respond and they don't know how to help, and no one likes that feeling. So it can really take a toll on relationships because people feel helpless, which can make them feel burnt out. So it's not good for relationships. And I think the big point that I made throughout was this problem solving approach that if suicide is the only option on the table for you, you're not going to be able to see any of the other options that might be available to solve whatever problem is haunting you. So if we can at least take suicide off the table, even just temporarily, then we can try to see what other options are there.
Great. One other question we have, are you aware of any additional LGBTQ plus resources considering the current defunding of the Trevor Project and cuts from the LGBT option on the 988 crisis lifeline when dialing in?
I'm offhand, I don't have LGBTQ specific resources for suicide prevention, but I would be, when I share my slides, I would be happy to take a look and add any specific resources there.
Thank you. Thanks, Allie, for that question. It looks like that is the time that we have. Thank you so much, Dr. Jacqueline Ross, for your expertise. This was really enlightening and informative. I really appreciate you taking the time today. If you would like,
thank you.
of course, if you would like to learn more about us at Patagonia Health, feel free to visit our website at www.patagoniahealth.com. We are an integrated EHR, practice management, and billing solution. Have a great day, everyone.
Great. Thank you so much.
Yes.